Hi, my name is Erin Ogden, and today I'll be presenting about orthorexia nervosa. This presentation will mainly focus on the research up to this point, but will also include examples and insights from my professional experience as applicable. We'll start by defining orthorexia and providing a little bit of historical context behind the term. So, Stephen Brotman was a holistic medical practitioner who coined the term back in 1997. And he started to observe a pattern of excessive preoccupation with healthy eating among his patients. And he used the term ortho, meaning right, to indicate an obsession with eating the right foods. And these were foods deemed healthy, clean, or pure by his patients. With time, researchers and other practitioners began to observe the same phenomenon, which started to include severe dietary restriction on the basis of ingredients, additives, manufacturing processes, or agricultural practices that eventually led to an elimination of entire categories of food. And eventually, the term orthorexia nervosa emerged to describe a more severe variant of this phenomenon characterized by intense anxiety, distress, and functional impairment in some cases. And although the term is used worldwide, there is currently no standardized definition or diagnosis in the DSM-5 or ICD-11. Interestingly, even though the Journal of the American Medical Association referred to orthorexia nervosa as a new eating disorder back in 2001, and by 2011, more than two-thirds of surveyed health professionals said they had observed orthorexia nervosa in practice, it is still not formally recognized. And this is because categorizing orthorexia nervosa as its own condition has been challenging due to lack of empirical research. Also, some propose that orthorexia nervosa is simply a variant of anorexia or other eating disorders, or that it's too similar to other conditions with similar presentations. And it can just be really difficult to distinguish between a positive focus on healthy eating and a pathological focus on healthy eating. However, it's believed that those with orthorexia nervosa transition from an appropriate desire for healthy eating into a pathological obsession for clean eating that leads to malnutrition or other medical problems and/or social dysfunction. Dr. Brotman and other researchers have identified two stages in the development of orthorexia nervosa. In the first stage, it's innocent, choosing to eat a healthy diet as a result of wanting to make lifestyle changes or manage a certain health condition. And for many people, it may remain in this stage as positive changes and it's not obsessive or pathological. In the second stage, however, there is an intensification of the pursuit of those dietary changes or focus on nutrition that turns into an unhealthy obsession. And it is only in this second stage that implicates pathology. So Dr. Brotman found that his patients were inadvertently harming themselves psychologically, socially, and physically as a result of their pursuit of health. And this is what we are watching for in clients to identify a pathological obsession with healthy eating. Next, we'll take a look at orthorexia nervosa in practice and review risk factors, symptoms, behaviors, and outcomes that you may notice in individuals who are suffering from orthorexia nervosa. As we talk about risk factors associated with orthorexia nervosa, if you're familiar at all with risk factors for other eating disorders, you'll notice that there's a lot of overlap here, specifically having a family member or relative with an eating disorder, or high stress and anxiety or dissatisfaction with other areas of life, turning to diet for a sense of control, and personality behaviors like perfectionism, neuroticism, obsessive compulsive traits, and a history of dieting and body dissatisfaction are all common to a variety of eating disorders. However, in orthorexia nervosa, some risk factors that we're going to specifically watch out for is an individual having a childhood illness or chronic disease like diabetes or fibromyalgia, a medical diagnosis requiring a specific diet, or medical problems that are difficult to address, such as acne that may not have a specific treatment or protocol. And this is because individuals with these conditions can start out in that innocent stage 1 of orthorexia nervosa, where they're making changes to their diet in an innocent or positive way, trying to manage their condition well. But we want to watch these individuals because it can turn into that second phase of orthorexia nervosa, where it becomes a pathological obsession with managing their condition through diet. Second, sociocultural risk factors are really key in orthorexia nervosa because of the impact of the media's portrayal of idealized bodies and specifically clean eating trends, and also social media promoting trends and fostering comparison, as well as societal norms equating health with dietary purity. And interestingly, high Instagram use in one study was associated with a greater tendency towards orthorexia. And this is because the healthy eating community on Instagram tends to have a high prevalence of orthorexic tendencies. And there's a broad access to nutrition information from a variety of sources on Instagram. And interestingly, some researchers argue that it's not plausible that this disorder, orthorexia, could have existed significantly in the pre-internet era, as findings from this study indicate that both the shifting culture of wellness ideals and the access to nutrition information itself are central fuel for developing orthorexia nervosa. And finally, having a fear of disease is a risk factor for orthorexia nervosa, and also access to health information. So many studies have shown that individuals like medical professionals, like dietitians and yoga, other health professionals like yoga instructors, often are at higher risk of developing orthorexia nervosa due to the increased knowledge of nutrition and health information. Moving into symptoms that you'll notice in individuals with orthorexia nervosa, as we distinguished earlier, there's the obsession with the quality of food. And what we mean by that is the source. It could be the processing, packaging, macronutrient profile, etc., as opposed to the quantity of food. And this is one of the main distinctions between orthorexia nervosa and anorexia nervosa, is that typically in patients with anorexia, they're more concerned about the quantity, the calories, versus in orthorexia, you'll notice that it's less concerned about how much they're eating and more concerned about where the food came from, what's in it, and is it deemed healthy enough. So they become overly concerned about the impact of the food on their health rather than the impact of food on their body weight or size, which again, relating back to anorexia, they're typically more concerned about the impact of food on their body weight and size. And you'll often see a worsening depression, mood swings, and anxiety with the intensification of their obsession with healthy eating. And important to note that the appearance concerns are not central for these individuals, and there typically isn't an explicit search for thinness. And so although orthorexia nervosa does not typically correlate highly with body dissatisfaction, some researchers assert that it is perhaps due to the fact that individuals with orthorexia nervosa have already achieved the body type that they desire. So we're still kind of trying to figure out whether or not there still is some body dissatisfaction in these individuals, but it may be because typically individuals with orthorexia nervosa may have already achieved their desired body weight. So some behaviors that can present in individuals with orthorexia nervosa include elimination of entire food groups, generally without medical, cultural, or religious reasoning. Another behavior might be stringent or ritualized eating patterns, which can be common in other eating disorders, avoidance of eating in social groups or dining out, distancing from family and friends who do not share similar beliefs about food. And this next one is a really important feature of orthorexia nervosa, which is that they become very critical of others' eating habits who do not adhere to clean or pure diets, and they're often vocal about it. Next, excessive amount of time planning, obtaining, preparing, and or eating one's food can be an important indicator or a behavior seen in individuals with orthorexia nervosa. And finally, an increasing avoidance of foods because of food allergies without medical advice or diagnosis can be common as well. Some of the outcomes you may see in individuals with orthorexia nervosa include gaining a satisfaction, esteem, or spiritual fulfillment from eating healthy or following a pure diet. Also, intense guilt when deviating from strict dietary rules or guidelines. Also, their rigid eating rules may result in low body weight, but not always. And in orthorexia nervosa, it is usually a side effect or a consequence rather than a result of body dissatisfaction, like in anorexia nervosa. The low body weight is usually a consequence of a desire to lose weight or dissatisfaction with their body. And finally, food selectivity may result in nutritional deficiencies such as anemia, weight loss, malnutrition, hormonal disturbances, loss of menses. I want to pause here for a moment and share an example of a patient that I worked with who was diagnosed with anorexia but presented more like orthorexia to illustrate some of the features we've talked about. While she presented with behaviors like restriction, rapid weight loss, and low body weight common to anorexia, in talking with her, I discovered that her restriction was motivated by a desire to eat a healthy diet, and she learned certain things from social media. She began to cut out and restrict certain food groups like processed foods, foods with added sugar, certain fats, and she focused on eating low-calorie, high-volume meals and snacks. Her goal, however, was never to lose weight, and she couldn't figure out why she was losing so much weight because she felt like she was eating all day, but ultimately she wasn't getting enough calories as a result of her strict diet rules. The restriction resulted in loss of menses, hair loss, difficulty regulating body temperature, etc., that are common features of malnutrition. She slowly stopped eating meals with her family and going out with friends because they didn't eat the way that she did, and she had to quit varsity soccer as a result of malnutrition. The other interesting distinction working with this client was that there was no fear or anxiety over restoring or gaining weight, which is typical in anorexia. She actually was anxious to gain weight because she felt like she didn't look healthy and she couldn't gain muscle and she wanted her period to return to normal. So I just wanted to share this example so you can kind of start to notice some of these features that may occur in individuals with orthorexia nervosa and how they may present differently than anorexia or other eating disorders or even other conditions. One of the main reasons that orthorexia nervosa remains controversial and without its own distinct criteria is due to difficulty differentiating orthorexia nervosa from other conditions with similar presentations, such as anorexia nervosa, obsessive compulsive disorder, and ARFID, or avoidant restrictive food intake disorder. So we'll spend a little bit of time going over similarities and differences between these conditions, and you'll also have more time to go over this in your learning module resources. So we're really able to distinguish between orthorexia and other conditions when we look at the primary focus and underlying motivations behind the disordered eating behaviors or the restriction. So in orthorexia, as we noted, the focus or the restriction of certain food groups is based on food quality and the desire to maximize health, versus in anorexia, they're restricting their intake based on food quantity, right? Just the amount of calories or the amount of food that they're intaking. And it's motivated by a fear of obesity or disturbed body image or a drive for thinness. And in OCD, the restrictions that you might notice if someone with OCD is restricting food intake is usually based on contamination of food. That's their concern. But usually an individual with OCD is going to have other obsessions other than food, whereas in orthorexia, their obsession is primarily centered just on food intake versus other types of obsessions that you might see in individuals with OCD. And another important distinction between orthorexia and anorexia is that individuals with orthorexia tend to flaunt the behaviors. They're talking about their behaviors, promoting their behaviors to other individuals, versus in anorexia and OCD, the behaviors that they're experiencing, they're usually secretive about because there's an element of shame. Whereas in orthorexia, they're typically prideful of the behaviors that they're engaging in. And then one last distinction I want to make here is the difference in the types of thoughts that they're having. So in orthorexia and anorexia, they typically are having egosyntonic thoughts, which just means that their thoughts are in line with their ideal self. Versus in OCD, the thoughts that they're having are typically unwanted or intrusive or repulsive, and they're not in line with who they see themselves as or who they want to be. And they typically can recognize their behaviors as excessive or unreasonable, whereas in orthorexia, they may not have that same insight to realize that their behaviors are excessive or unrealistic. And I also want to note, especially for orthorexia and anorexia, that these similarities and differences allow for the possibility that orthorexia nervosa is a discrete disorder, simply a variation of anorexia nervosa. It may precede full onset of other eating disorders, or that it manifests in the recovery of an eating disorder patient, or that it may simply be a coping strategy for individuals with anorexia nervosa because orthorexia is typically more socially acceptable behavior than anorexia, so it may kind of be a mask for anorexia nervosa. So these are all possibilities, and again, why orthorexia remains without its own distinction up to this point. When comparing orthorexia with ARFID or even other conditions, again, we want to get to the root of the why behind the behaviors or the restriction. So in orthorexia, again, the restriction is taking place because of concern over health and purity of foods. They're worried about the impact of food on disease. And it's typically a longer term fear of the consequences of food and eating. So looking at the development of cancer or diabetes, other diseases that they may fear developing in the future, versus in ARFID, which is typically diagnosed in younger children, but not always. The selective intake or restriction is maybe the result of a conditioned negative response to food, such as an inexperienced choking on food, or just a general lack of interest in food, or sensory properties like texture that are causing them to avoid certain foods. But in this case, it's an acute focus on short-term impact of eating. So what's going to happen immediately after I eat this food? Am I going to choke? Am I going to vomit? Am I going to hate the texture in my mouth? And so, again, we can really kind of tease out the differences between these two if we just look at the why behind the restriction. But in both of these cases, you'll generally see failure to meet energy needs, weight loss, and social mental impairment. Now that we've talked about what orthorexia is and how it presents in practice and kind of distinguished between other conditions with similar presentations, let's move into talking about treatment approaches for individuals with orthorexia nervosa. I want to briefly touch on screening tools for eating disorders and specifically orthorexia nervosa. And screening tools are not diagnostic eating disorder tools, but rather used to detect the possibility of an eating disorder and identify when a comprehensive assessment is warranted. So the Ortho-15 is widely used in orthorexia nervosa research. However, it has been found to have questionable psychometric properties, and it was developed early on and lacks questioning some key features of orthorexia nervosa. So researchers are really moving towards trying to find other screening tools that are sensitive to pathological, healthful eating and that are more reliable and sensitive. One of those tests includes the Eating Attitudes Test, or the EAT-26, which is one that we'll focus on in this learning module, and you'll have the opportunity to look closer at this questionnaire. But it's widely used and sensitive to different eating disorders, and there was a study done to determine whether or not this Eating Attitudes Test was also sensitive to pathological healthful eating, and they found that it was. So this is a quick self-administered test that you can use in practice with patients or clients who you suspect may have an eating disorder. And the report can indicate whether or not this individual warrants a more comprehensive assessment, and then you can refer them to a trained professional who can then determine whether or not they have an eating disorder. And finally, the 1017 is another screening tool that is promising, showing good psychometric properties. It just needs more research to verify the findings. I've included on this slide a couple of other helpful questions that can be useful to incorporate into your initial assessment with clients to screen for eating disorders. And really what we're looking for is the worry factor. So the worry factor is one of the biggest indicators. If a client has too much concern over what they eat, this stress could be worse for their health than what they're actually eating and can lead to orthorexic tendencies. So we're really trying to screen for that worry factor. And it's particularly important to screen those with chronic illness or disease because of the potential to become obsessive about their diet or seeking a sense of control. The importance of a team approach in eating disorder treatment cannot be overstated, and you'll notice that that team includes physicians, therapists, dietitians, and an element of family and social support. I've included a list of treatment interventions for individuals with eating disorders and specifically orthorexia nervosa. The points in bold are the areas where dietitians can really make an impact, and we will go into these in more detail on the next slide. But interventions should be individualized based on symptoms that are prominent for each patient or client. One of the most important features of dietary management of orthorexia nervosa will be the meal plan, and this will include or can include weight restoration or a maintenance plan. It also should include adding variety back into the diet, and you can achieve this by having the patient create a hierarchy of challenging foods or foods that they're afraid of. And you work through a process called systematic desensitization. So slowly adding these foods back into the diet in order to improve their relationship with these foods and also improve the nutritional adequacy of their diet. Second, psychoeducation can be a huge tool that dietitians can use to help patients in their recovery. So this will be utilizing evidence-based science information that can help these individuals identify false or unnecessary food beliefs. And I want to note here that it can be really difficult to help patients or clients deconstruct these beliefs that are so intertwined with their identity, but it can also be really helpful in their recovery. And also including intuitive eating and mindfulness principles in my own experience and in the research has shown to be really beneficial for eating disorder treatment. And finally, identifying and managing triggers that could be contributing to orthorexic behaviors. So we want to take a look at the aspects of a patient's life that may be triggering these behaviors. And you'll notice from the list that the triggers can be ever present for these individuals. So our goal will be to work with them to eliminate or manage these triggers in a way that promotes recovery. As we wrap up, let's go over some important considerations with orthorexia nervosa. First, more research is needed. So we need more research to improve our ability to determine whether orthorexia nervosa precedes or follows the onset of other eating disorders, OCD, or both, or whether orthorexia develops independently. Also, currently available instruments have been unable to distinguish between anorexia nervosa and orthorexia nervosa, and in some cases between individuals with a knowledge of a healthy diet and those with pathological obsessions. And although individuals with orthorexia nervosa can be diagnosed as having an other specified feeding or eating disorder or an unspecified feeding or eating disorder under the DSM-5, there are problems inherent to non-specific classification of disordered eating, most notably the potential for reduced access to appropriate treatment, which leads into the next point, which is the importance of having official diagnostic criteria if orthorexia nervosa is indeed its own distinct condition, because having official diagnostic criteria improves the access to nutritional research and developing diagnostic screening tools, and improving our ability to screen and identify individuals who may be suffering from orthorexia nervosa, as well as improving treatment protocols. And finally, we have to consider the impact on children. So one of the most alarming trends associated with orthorexia is that children are picking up on some of these tendencies. Kids who watch their parents obsess over certain foods may mimic that behavior, and well-intentioned parents who strictly limit their children's sugar intake or try to feed them only organic foods, for example, may instill a sense of fear in their children that other foods are bad or that scary things could happen if they eat them, which can lead to nutritional deficiencies in children. So these are all things that we have to take into consideration when thinking about orthorexia nervosa.
So, whether or not you work in the field of eating disorders or you're just generally interacting with clients on a day-to-day basis, there's many things that dietitians can do to screen and identify for orthorexia nervosa and promote a healthy relationship with food. So, we'll take a look at that. First, how to screen and when to refer. So, like we talked about, you can include screening questions for eating disorders in your initial assessments with patients and clients. And you can encourage a patient or client to complete the Eat 26 or another self-assessment if you're concerned about their eating or exercising behaviors. Bottom line, if we don't ask, we will miss it. So it's essential that we add this area of assessment for eating disorders and orthorexia nervosa to our patient evaluations. And finally, refer to experienced health professionals such as a physician, an ED-trained therapist, and dietitian if this is out of your scope of practice. So if you're not familiar with eating disorders, if you don't know how to identify or treat and work with patients with eating disorders, always refer to a trained therapist or dietitian, or get a second opinion from a physician about their nutritional status if you are unsure. Finally, one of the biggest impacts that dietitians can have in this space is encouraging a positive relationship with food in our interactions with patients and clients. So this includes emphasizing intuitive mindful eating principles, which is, permission to eat and nourish the body appropriately. Talking about how all foods can fit in moderation as part of a healthy diet, and neutralizing foods, removing labels like good and bad from the foods that we're recommending to clients. We can also work with clients on honoring hunger and fullness cues, helping them learn how to recognize and respond to those appropriately. And finally, honoring health through gentle nutrition, which means that we're not disregarding the importance of diet in overall health, and we recognize that there's certain conditions that require certain dietary changes, but we can work with clients in a non-judgmental way to help them be able to achieve those goals in a positive way. So we can do that by focusing on what can be added to clients' diets instead of really emphasizing things to avoid and eliminate. We can also help people reframe negative judgments. So if they're talking about their eating habits really negatively and experiencing a lot of guilt and shame, we can reframe that in a way that's positive and hopeful. For example, for a diabetic patient, instead of them thinking, I can't eat this, an intuitive eater might think, my blood glucose doesn't respond as well to this food, and we can help them adjust their food choices as needed. We can also talk about how nutrition is one aspect of health promotion. It's not the only thing that's going to result in our health, and that also other areas of our health are equally important, like mental health, social and relational health, etc. And finally, we can consider the impact of our nutrition messages. So the way that we package and present our messages to clients matters and can impact their relationship with food. So just really thinking about how we're presenting informations to clients. And
Thank you for watching this presentation and participating in the Orthorexia Nervosa learning module.